The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
So I appreciate the opportunity today. I think we're talking about a very timely and important topic, which is prostate cancer survivorship. So you want to really delve into some of the treatments that patients undergo for prostate cancer, and it's really more what patients can expect after that, and really how we can help as men's health urologists in navigating this space. So prostate cancer is the most common cancer in men outside of skin cancer, and estimates say it affects 1 in 8 men. And so there are nearly 3.3 million prostate cancer survivors. And so we see a lot of patients where when you get this diagnosis of cancer, you hear the C word, all the patients are thinking about, and rightfully so, is how can I make it out of here alive, right? And because cancer has such a stigma in our society. And what we find is that prostate cancer, generally speaking, is very treatable. Our urologic oncology colleagues are very skilled, whether it's with surgery, radiation, hormonal manipulation. They can generally get most patients through. And at the time of diagnosis and treatment, patients are not thinking about what will my life be like a year after my prostate removal or 3 years after my radiation therapy. And today's webinar is more just to kind of delve into these issues and what we see. So like I was saying, the relative 5-year survival rate of prostate cancer diagnosed in its earliest stages is over 99%. And so we want to talk about some common side effects that we see after prostate cancer treatment, which I want to really emphasize are very treatable. And it's never too late to see urologists such as myself or my colleagues in this field who specialize in men's health, and we can really help patients. So bladder leakage and ED kind of being some of the big things we see. So the first and top priority is to follow the recommendations of your urologic oncologist, your radiation oncologist, and medical oncologist, and being cancer-free is the top priority. But then once we get to the other side, some side effects may be seen. So the first topic we're going to delve into today is bladder leakage, or what we call post-prostatectomy incontinence. So male incontinence is a common but treatable condition where a man will have difficulty controlling his urinary stream after surgery. So there are essentially 2 types of incontinence, broadly speaking, okay, in all comers. There's what we call stress urinary incontinence, which is where when you cough, sneeze, bear down, when you lift heavy things, you may leak a bit of urine. The other is called urgency incontinence, which is where when you're trying to go to the bathroom and trying to hold it, the urge to go is too much, and then one may leak themselves. Now, and you can have something in the middle called mixed incontinence, which is a component of both of these. Now, there are many causes of these various forms of incontinence: prostatic enlargement, prostate cancer, which is what we want to delve into, neurologic diseases, Parkinson's being one of them, multiple sclerosis, ALS, all these. And then, but really to kind of hone into what the focus today is, which is in prostate cancer survivors, especially after prostate removal for prostate cancer, 3 to 10% of men will experience moderate to severe erectile dysfunction, which may require a secondary procedure to help get that under control. Now, some degree of incontinence right after prostate surgery in the weeks after is expected because the prostate houses the main sphincter, which is important in men's being able to hold their urine. But essentially that over the few weeks after prostatectomy, in most cases, patients are down to no pads or maybe a small panty liner pad a day. But in some patients, this is persistent, and then we essentially can offer some options for that. The options that we have for patients after prostate cancer surgery who may be having leakage. So the first option in very minor cases and really in patients who have more significant incontinence, and what they may use is pads or underwear, right? And so this is the leakage that one may have day to day. And I see patients, they use just guards that you can pick up at your local, grocery store, even up to like Depends and things of that nature. Now, there are better, some products are better than others, I would say. And so, I have an example here today of a product which is Protect Dry. So essentially now there are underwear products that are coming out that have these inbuilt shields that are hyper absorbent and that you can wash multiple times. On this one, over 100 times. And MenMD offers this, and is a good product that can be used in minor incontinence, I would say, more so. Then clamps are used in some cases. So sometimes in a patient who may not be a surgical candidate or who does not want to undergo surgery, essentially this is a clamp called a Lundberg clamp or a Cunningham clamp, which you would essentially put the penis, imagine that, right through that area, right? And so now can be uncomfortable, certainly, but in some patients this is a decent option, and it comes in different adjustable sizes here, as you can see, and it's actually quite easy to use. Now, medications are more, I would say, in patients who have that urgency incontinence, where when they feel the urge to go but they can't hold that, then we find in those patients this helps. But in the patients who are leaking with coughing, sneezing after their prostate's removed, medications generally are not as effective. And then the other two are more kind of the surgical management. So urethral slings, which we would use in kind of mild 1 to 3 pads a day in a non-radiated patient. That's pretty important, we find. And then artificial urinary sphincter, which is the workhorse of this in patients who are leaking even up to, I see, 12, 15 pads a day. They stand up, they fully leak. That device can help. So next slide. So one thing actually I want to bring up is, sometimes before even patients go into their prostate cancer surgery here in Cincinnati, we will see them and do a pre-prostate prehab visit. And what that means is we will teach them how to do Kegels exercises. And you may have heard of this. So Kegels exercises, if you think about if you're peeing and you cut your stream off halfway, that muscle that internally you recruit to gain that continence, if men can strengthen that, sometimes pre-surgery or even after surgery, time is, it's never too late for that, that can help too. So going into for mild to moderate stress urinary incontinence after prostate cancer surgery, a male sling is quite a good option. So the Boston Scientific Advanced Sling, it's generally it's undetectable to others. It's a quick 45-minute procedure. We'll do a scope before just to make sure the patient is a candidate. And essentially what it does, it acts like a hammock and tensions the urethra and changes essentially the angle of it, because what can be changed after the prostate's removed, and can help to support and bolster that area. So in patients I find who leak maybe 1 to 3 pads a day, and the key is that are not radiated. So unfortunately, radiation, what it does is it takes the blood supply, or the vascularity away from the tissue a little bit, and it's not as pliable for that sling. So we do unfortunately see patients who have had slings who have maybe leaked more than that, or radiated, and generally it brings it down a little bit, but not enough, right? So in those patients, we may do the next treatment even in addition to a sling. But the great part of a sling is it's not something you have to work on a day-to-day basis. I mean, once it's in, it's tensioning. Patients are immediately continent after the procedure. They may have a catheter for a day or two after, and then we pull it out. And yeah, it's a great option in certain patients. And so then the workhorse of kind of severe stress urinary incontinence after prostatectomy is the artificial urinary sphincter, or the AMS 800. So this has been around since the early 80s, believe it or not. And so essentially what it is there's a pump in the scrotum, or the control pump. There's a cuff that we put around the urethra, and a pressure regulating balloon, small, with about 3.6 centimeters in diameter, that we put in the abdomen that is imperceptible to the patient. So when you want to pee, you'll feel that urge, you'll give that pump, and I have one right here, so you'll give it 2 or 3 firm squeezes, squeeze, squeeze, squeeze. And what that does is it opens up that cuff on the urethra, boom. And so then for about 45 to 60 seconds, it stays open and the patient pees, and then on its own, it closes back down. So it essentially mimics the action of what the sphincter was doing when it was functional in the patient. And so, I mean, and this device, I think, works remarkably well, even in patients with extremely high volume, what we call gravitational incontinence. They stand up and boom, they'll just leak. It works. And there's over 95% patient satisfaction with the implant, with this artificial urinary sphincter. And really, I mean, it can change a man's life, to be honest with you, because patients, until a man loses his continence, you don't know how important it is. For a guy, you know, a 25-year-old on the street who's never thought about it, it's not even something they can fathom how big of a deal this is, right? And so if you're incontinent to this degree, you can't have sex, you can't go in a swimming pool, it's hard to play golf. I mean, there are so many downsides. So once you can do this for a patient, and it's an outpatient procedure, once again, it takes 45 minutes to an hour to do. We leave it deactivated for about 6 weeks to let all the swelling go down, and we bring the patient in the office, turn it on, teach them, and they're off from there. So really good option in select patients. So another common side effect that we see after prostate cancer treatment is erectile dysfunction. So one thing I like to bring up, just as a general thing for people to know. So what is the different stages of, you know, who may treat you for erectile dysfunction, right? So certainly one's PCP, family doctor, they have a general understanding of erectile dysfunction, and they can prescribe medications, Viagra, Cialis, Levitra, things like that. Now, a urologist is a doctor who is trained 5 to 6 years of residency, and we focus on the surgical and medical management of male and female urinary system and male reproductive organs. Now, you know, urology is a broad field, kidney transplantation to stones, to cancer, to female urology. So there's many things. And then prosthetic or urology or men's health, kind of what some of my colleagues and myself do, is we just specialize in these men's sexual health, life after prostate cancer, prosthetic devices like the sphincter, the sling, the penile implant, injection teaching, things like that. So important to see someone in the medical field. I think a lot of times there are these shockwave pop-up men's health clinics that you have to, you know, be a little weary of. And so I think seeing someone who can offer you all of these options and not just one option is important. So ED post-prostate cancer treatment, it can be after certainly the surgery for prostate cancer, radiation, which generally happens about 2 to 3 years after the radiation treatment, or in patients who receive what's called androgen deprivation therapy for more advanced prostate cancer. And the nerve damage can be short-term or even permanent in these patients. So, all the options that even for a regular diabetic patient who has erectile dysfunction are on the table. So oral medications, vacuum devices, intraurethral gels, injections, or a penile implant. So oral medications, I think most men have heard of this, Viagra, Cialis, or sildenafil and tadalafil, the generics. So these can be taken, in the case of Viagra, 30 to 60 minutes before sex. So Cialis a little more, just because the half-life's longer. And essentially, they just enhance blood flow to the penis. And they do require sexual stimulation, but there are certain patients who just don't do well with them. So certainly patients who are on nitrates for chest pain, it can cause a big decrease in blood pressure, which can be unsafe. Alpha blockers, you have to be a little careful too. And then the main knock is sometimes some patients will get some side effects, so facial flushing, nasal congestion, blurred vision, headaches, and essentially it increases blood flow to all the extremities, with the head being an extremity, so that manifests as headaches and the such. But this is generally the first line of erectile dysfunction management. And I'll tell you, when in that whole prehab program that we recommend, before patients undergo prostate cancer, sometimes we will start them on a low dose Cialis, for instance, daily, just to get some blood flow to the penis. And even after they have their surgery, they'll continue that just to, of course, you may not be having sex, a few weeks after your procedure, but just to keep that blood flowing to the penis, I think has been shown to have some good benefits in keeping length and girth, even potentially over time. And then another part of it will be the vacuum device as well in these patients that we do. So MenMD has had some great products, that they can mail anywhere around the country at an affordable price. And then so we send prescriptions down there all the time, and they the team's very good there. So a vacuum erection device. So this is a hollow plastic tube that can be hand or battery pump operated, that essentially, like that image there, goes on the penis and sucks blood into it. And then you can sometimes use it in conjunction with a constriction ring at the base to kind of trap that blood in there. So patient satisfaction rates range from 68 to 80%. The most common side effects: penile numbness, bruising, discomfort, blocked ejaculation. But in patients who've had prostate cancer, especially prostate removal, they're not ejaculating anyway, so it's not as big of a thing that we obviously hear about then. But VED that is used 3 to 5 times per week for approximately 20 to 30 minutes each. That's what we would recommend for prostate cancer prehab and rehab. And we've shown that in these patients, it limits the loss of length and girth that patients can experience after prostate cancer treatment. So this is one of the things that is disconcerting, but like in the end, the top priority is taking care of the cancer. But sometimes patients, just if they're not exercising the penis, I think the use it or lose it mantra there is some truth to that. So vacuum erection devices do have a good role in post-prostate cancer patients, just to keep exercising essentially the penis. And once again, MenMD has all the options in this and provide a seamless operation on how to get vacuum erection devices in patients' hands. And then next is intracavernosal injections, right? So to me, this is this is the last line in the medical management. So essentially, in patients who have tried pills and failed, maybe they've tried intraurethral gels, they've tried vacuum erection device, and it's still not able to penetrate during intercourse, right? So what the injections do is, instead of a medicine that goes throughout the body, you're injecting the medicine directly into the penis, and it essentially increases blood flow and maintains an erection strong enough for the entirety of the sexual intercourse. Now, it's a mixture essentially of 2 to 4 of these medications. So if you have papaverine and phentolamine, then generally that's called bimix. If you add alprostadil, that's trimix, and then you can add a 4th component, atropine, and it becomes quadmix. And so essentially it's a gradation, and certain patients will like certain things. So for instance, some guys after injections will get a dull, achy feeling. That may be the alprostadil, just the way that works, and then we'll titrate the doses. And so very important to have your urologist who kind of specializes in this and knows just the intricacies of what each patient needs, right? So then this is the intraurethral gel therapy for ED. So this is actually a thing that I think MenMD is ahead of the curve, especially in the United States. I think before, patients are ordering this from abroad a lot of the time. And so some patients just are not going to do needles. I get it, and they don't want to do a penile implant. So this is a kind of a middle ground. I'm actually a big fan of intraurethral gel. And so essentially this is the same medications we discussed for the injections, but you can inject it into the urethra, and so the urethral mucosa can essentially absorb through there. So the onset of erection is 5 to 15 minutes, and success rates are up to 65%. So now the most common side effects, obviously, when you're injecting something in the urethra, so there can be a bit of urethral pain or burning. And then that priapism, that's a prolonged erection, more than 4 hours, and that can be seen with any erection treatment that we give, and if that happens, then you have to seek medical attention. So but the MenMD have a few formulations that are very helpful in certain patients. So certainly ICI is the most effective non-surgical treatment for erectile dysfunction, and success rates are up to 90% in the clinical literature. So we talked about the side effects, the priapism, and then obviously you're putting a needle in the penis, but I mean these are small needles, like diabetic 31 gauge needles. So while yes, they can be bruising and swelling, especially maybe in patients who are on blood thinners like Plavix, warfarin, and things of that nature, but if you just hold pressure, generally not so bad. Now, penile fibrosis, scar tissue, certainly is reported curvature, which is called Peyronie's to the penis, just from the trauma of the injections. But a lot of times, I'll tell you, it's hard to disentangle in post-prostate cancer patients. Is this from the actual shot, or is this that they, like I see a guy who had his prostate out 10 years ago, and he hasn't had an erection in 10 years. Probably the lack of good blood flow, good oxygenated blood flow is probably the bigger cause of that fibrosis, or fibrosis is another word for scar tissue, essentially formation in the penis, right? So hard to disentangle, but possible. So these medications, the injections generally need to be refrigerated or frozen, and then the vial should be discarded about a month after the first puncture. So we're going to do a live demonstration here, but just a few highlights of this. You want to, and I'm going to kind of show it here with our model. So you want to inject at either 1 to 3 o'clock on the penis, or 9 to 11 o'clock on the penis, right? And so the reason for that is that at the 12 o'clock region, all the nerves run. So you'll have a lot of sensation there, arteries, veins. And on the bottom side of the penis at 6 o'clock is the urethra. So you don't want to obviously put the medicine in the urethra, because the way the erection works is the paired corpus cavernosum is where the blood fills up, right? So essentially, we would start with an alcohol pad right here, okay? Here is the medicine. So always you want to disinfect right here at the rubber stopper, just to clean that area, okay? And then here's the needle, okay? So very small. I mean, I'm gonna show you this. You barely can even see this, the gauge of this needle, right? So let's say I wanna go up to about 20 units. So I'll pull it up to 20 units, okay? And then I've already disinfected this. So then I'll put it into through that rubber stopper, and I'll actually inject here, and you'll kind of see some air bubbles go in, right? So then, and then you'll pull back to where, back to that 20 units, and that's that. Okay, perfect. So now I'm ready to go with this shot. So on the penis as well, then, just at that side, and I prefer also patients, I tell my patients to go near the base. You could go up here, but it also hurts more towards the end of the penis. You go, I mean, the head of the penis would hurt a lot, so I would avoid. So you just go at the base at 9 to 11 or 1 to 3. I like 9 o'clock just as easier, you just know it's right there on the side, and then essentially you just push it in all the way. And I have patients make a little indent there, then you're in the corpus cavernosum and not in the skin, and then you inject, pull out the needle, and then just hold some pressure there, right? I think that helps a little bit, just to any bleeding and just to keep the medicine kind of staying in the chambers of the penis we want it. And then essentially, as always, you want to dispose of your sharps, just throw it in there. And yeah, so that's that, and then we do a test erection in the office generally, and kind of find what dose is good for what patient, and then they can tinker with that a little bit at home as well. So I think intracavernosal injections are a great option, and certainly in patients after prostate cancer, I find that we do like to try it, especially early on, like if it's been even 6 months to a year after, let's say, prostate cancer removal, and they're struggling with erections and they've tried pills, vacuum, and they're still unable to penetrate. There's no reason to have these guys wait, these patients, and say, no, you can't have sex. No, I mean, let's do injections and see. Because also that's helping. That's a form of penile exercise to get some oxygenated blood into the penis, and so we're aggressive about trying to get these patients into the treatment cycle early, right? Because I just see too many patients, and the reason that we're doing this webinar tonight, the first one about life after prostate cancer for MedMD, is that there are so many patients we see who've had their prostate out 10, 15, 20, 25 years ago, and then they come in and say, why has no one told me I could have done injections, or I could have had a sphincter put in so I'm not leaking on my wife, or I could get a penile implant, and you know, so we need to spread the word that these options exist. So, and then this is essentially MenMD will send a log, so that essentially where you can you know, and I mean, I guess I'm showing it, but it's on the slide. But essentially where you can say how many units you use, when you use it, and that kind of, and there's a rigidity scale, so you can know you want to be between 7 to 9, because sometimes when you're so erect at 10, it can be painful. So this just helps for the patient to understand, you know, what's a good dose for them, and also the customer service team is very good, that you can call them, and you know, the pharmacy team, I mean, and then they can help you with that. So yeah. And then last is in the, you know, management of erectile dysfunction is the penile implant. So right, so the penile implant has been around since 1973. So last year was the 50th year anniversary. So penile implants have been around longer than pills, vacuums, shots. I mean, it was the first thing that essentially was done. Now, obviously, things have come a long way, but that idea has been there for quite a while. So essentially, it's 2 paired cylinders that are surgically implanted into the erection chambers of the penis, a pump that's in the scrotum, and a reservoir of fluid we tuck in the abdomen. So when a patient wants to have sex, he'll press the pump a few times, and it will pull the fluid from that reservoir into the chambers of the penis. Now, the erection with a penile implant is over 95% patient and partner satisfaction. The most common thing we hear from patients is, I wish I did this sooner. And the thing with this is then you don't need to do any, you know, pills, shots, vacuum devices. I mean, this is it. And it does not interfere with ejaculatory function. It doesn't affect really sensation, orgasm, ejaculation. Whatever those are pre-op, they will be after. And at 7 years, 94% are still in use and free of revision. There's about a 1 to 2% infection rate. I think that we know relates to a variety of factors, you know, operative time, surgeon experience is probably a huge one. So patients, obviously surgeons who do a lot of this have less infection than the ones who do a few. But essentially, I mean, there are multiple types of implants, but I mean, just a quick demo here just to show everybody. So, you know, the 2 cylinders, and so these would be in the penis. There's the pump right here, and so we try to surgically implant it in between the testicles in a kind of a place in a concealed spot. So, and then this reservoir, and this one has air, but this one, the real one, we put some saline in it and tuck it in the abdomen. So the key is, if you're in a locker room, no one will know you have it. It's fully internal. There's no part of this that is external. It's safe in an airport metal detector, safe in an MRI machine. So it's you know, it's a great option in patients who maybe have failed a lot of the medical management of erectile dysfunction, and it's something to think about. And there's even newer things that are always coming about in our field. This is why it's, you know, so interesting, and why I love my job the most. I think it's so gratifying because, for instance, one condition, and this is really applicable to today's audience, some patients, when they are having sex, they will leak. That's called climacturia, right? So when they climax, they leak urine. So now there's a newer procedure that we do when we put in the penile implant. We'll put a sling in at the same time, a little different the way I showed in the slides, across the penile implant. So when you pump up the implant, it tightens that, and so across the urethra, so the patient won't leak during sex, right? So we are always innovating and finding new avenues that we can help just patients who are struggling. So my take-home message tonight, before we get into the Q&A, is please go see your local urologist. Let us kind of, you know, help and you know, do what we love doing, and just really getting the word out there, and just treating patients who are suffering, and so here's a demonstration of the penile implant. So we'll just put that on too. Okay, so first thing you see, it's fully concealed, right? So it's nothing external, but now when you kind of look inside, so the pump is right there in between the testicles, so the patient will pump it, and what it's doing is pulling the fluid from that reservoir into the penis. Nice erection. You can stay hard as long as you want, whenever you want.
there's no such thing as a priapism with this. It's not going to stay too hard, and then you press the deflation button and it goes down, and that returns the fluid back to that reservoir. And the reservoir is non-palpable, meaning you can't feel it, but it's as easy as that. So it's an outpatient procedure, takes an hour to do. You go home the same day, and then we see the patients a few weeks later to show them how to use it. All right, and so this edcure.org is just essentially erectile dysfunction specialists in your area that you can meet with and talk to, and I think that's what all we can hope for. That the first step is everyone tuning into this webinar tonight. I commend everyone, and let's take the next step all together. And as men, we got to take ownership of our health. I think we sometimes don't do as good of a job as our female counterparts, but I think webinars like this are going to spread the word, and I think we're going to make a change for the best. So thank you. I mean, so this is a little, I'll tell you guys, this is controversial, right? So testosterone replacement therapy post prostate cancer treatment. So certainly, if someone has, like, for instance, metastatic prostate cancer, we give medicines to cut their testosterone down, because prostate cancer a lot of times is a testosterone or androgen dependent cancer. But so certainly in those patients, we would be very leery, or would not, I want to say, give testosterone replacement, because it kind of counteracts what those medications do. But now we are finding that in patients who've had their prostate removed and maybe for about 2 years after have an undetectable PSA, a lot of times their testosterone levels are not very good. And so, besides having ED problems, they're having low libido. So yeah, you could give them a penile implant, best one ever, but if they don't feel like having sex, you're not doing them a full justice. So sometimes, and you have to be a little careful, but you can give testosterone replacement. I think we this is something that we are doing more and more, and even in post-radiation patients, if the PSA has been undetectable or has plateaued at an acceptable range, we will, after a thorough discussion of the risks and benefits, go forward. And so testosterone replacement, I mean, this is a totally, it's a huge topic, but you can do topical gels, patches, shots. Pellets I wouldn't probably do in this population, because you want something that if the PSA was to spike up, you don't want it something that's going to keep emitting testosterone. But we have now there's new oral testosterone products like Kaisertrex, which are incredible, and you can do so. So this is an evolving field, but something that I think if patients are struggling with, is something to bring up to your urologist. And a lot of times I have been doing testosterone replacement post prostate cancer treatment in patients who are suffering, for instance, from low libido and fatigue and things of that nature. So
we're going to start with some general post-prostate surgery questions, as that's obviously the topic of discussion tonight. So first question here is, stamina normally greatly reduced post-surgery, and will I expect to ever get back pre-surgery energy levels? And I'm sure they mean sexual, but yeah.
Yeah, I mean, I think at first, certainly, I mean, after any surgery, but certainly prostatectomy, I mean, we can see a decrease in stamina, and especially if you're talking about sexual prowess. Yeah, I tell patients after prostate cancer removal, right, so prostatectomy, the first 6 months can be a bit frustrating, because the nerves that run on the side of the prostate are stunned. Even if your surgeon does a very nice nerve sparing, they're going to be stunned. And so the erectile function can be a bit sluggish to return. And also the big determinant is, what were your erections like before you went into your prostatectomy? If they were not very good at baseline, they're not going to get any better, right? But generally speaking, once patients hit that 6 month mark, now between month 6 to 18, they start seeing some potentially some better erections and stamina, and we go from there. Now, part of being sluggish could also be a testosterone, right? But at that stage, like 6 months out from a prostatectomy, I think it's too early to start a patient on testosterone replacement, because even if it's low, because you need to be able to trend that PSA being undetectable for, I think, at least about 2 years before I would consider it. So it's something that you have to do with a little bit of trepidation, or you have to be a little careful, but it's something that certainly can be addressed.
Alrighty, next question here. Does your penis length shorten over time as you recover from the prostate surgery without use?
Yes. Yeah, so there's certainly penile atrophy in both length and girth that we see. A study out of Italy showed that for every year, and this is not this is in all patients, every year a man has moderate to severe erectile dysfunction, he can expect to lose 0.5 centimeter of penile length, right? And so that, if you think about it, okay, 0.5 centimeter, maybe not bad, but you do that 5 years in a row, you lose 2.5 centimeters of length. That's 1 inch of length that generally it's hard to get back, right? So that's why we are trying to catch patients on the front end, right? Where when they get booked for prostate cancer surgery, I know all they're thinking about is the prostatectomy, and I get it, but we showed you the data that most patients make it out well and good. So we want to start this prehab with Cialis, vacuum devices, Kegels for the continence aspect early. The earlier you can start this and you can get ahead of it, you're not waiting 20 years after the patient had their prostate out and then they've lost a lot of length and girth and then trying to, do injections or an implant. So yes, the answer is yes. I kind of, went a roundabout way, but yes, there is some loss of length and girth.
Alrighty. Next question. Can prostate surgery cause lower back pain?
Potentially. I mean, if you're talking about the actual surgery, I mean, the way the patients are positioned, I mean, most days now they're even supine with the robot. So hard to know, depends how long the surgery went. There was like an untoward complication, like a lymphocele, which is, I mean, we're talking about pretty rare things then, or a urine leak that maybe could be back pain. But I'd say once someone's recovered, it'd be pretty rare.
Alrighty. Next question here. After prostate removal, what food/drink should I avoid for the rest of my life so that the cancer does not come back?
I don't think there's anything that if it's going to come back, it's going to come back. I mean, it's not, there's no food or drink that's going to change that. So no, go ahead.
Alrighty. Next question here, a bit of a review, but I think it's important. Are my ED meds like Viagra and others still effective even without my prostate?
So this is a point of contention, I think, right? So I think potentially so, right? But it depends also, like if you had a very aggressive cancer and the surgeon had to go wide and non-nerve sparing, then we have sometimes found that these medications are maybe not as effective, but we still like to give like a daily Cialis because we have found anecdotally that patients may still get some engorgement of the penis and so they just feel more fullness down in that area. So I think maybe not as effective, but we still in the first few months do like to give a PDE5 inhibitor. And some patients, I mean, I have patients who had a prostatectomy, had great erectile function before, and with a bit of sildenafil or Viagra, they're able to have penetrative intercourse and don't need anything more than that. So it's certainly possible.
Alrighty, we're going to jump over to some implant-related questions. So after how many years of surgery should I consider an implant?
So I've put in penile implants even like if a patient had very advanced prostate cancer and we know the oncologist had to go wide on the patient and they've had no luck in the first even up to like 18 months after the prostatectomy with pills, vacuum, shots, then yeah, we'll put a penile implant in.
Certainly. Alrighty. Another implant question here. Are implants the next best step after a decline in effectiveness when using injectables, so ICI?
I mean, each patient's different, but essentially to me, if ICI is not working, right? So ICI is more potent than pills or vacuum, then really your decision at that point is not have sex or like not have penetrative intercourse or keep struggling with the ICI. But if the ICI stops working, which we do see from time to time where patients get to a max dose that they shouldn't go more than, then yeah, it's a penile implant. And what I tell patients, I mean, I think there's sometimes a trepidation, right, to go into, oh, I don't want to put something in my body or this or that. But I tell guys, look, if your knee was not working and your orthopedic surgeon said, okay, so you need your knee replaced, you're going to do it, right? If your heart surgeon said, you need an aortic valve put in, you're going to do it, right? So many women have breast implants, whether cosmetic or for cancer. I don't think we bat an eye. I think we've just like, there's a bit of a stigma on penile implants, but it is a functional implant, right? Just like a knee replacement, or it's not like a breast implant, which is just a space holder, let's say, right? So I think that we need to kind of break that stigma that, it's a 1-hour procedure when done in skilled hands. Complication rates are very low in it, and we know that patient and partner satisfaction rates are over 95%, and most patients say, I wish I did this sooner. So I'm not trying to say it's the right thing for everyone, but I certainly think people shouldn't just discount it and say no. You know what I mean? Like, I think have a critical evaluation, and maybe you don't want to do it, and that's totally fine. But I just don't want people to discount it off the bat. That's all.
Alrighty. Next question here. So with implants, the head of the penis is soft. Will this be a problem?
Essentially the basis for this question is that the 2 erection chambers of the penis where we put the implant, they are nice and rigid, but the head of the penis, the engorgement of that comes from the urethra. And so that's more the urethral blood supply. So that's probably the main difference between a natural erection that one had when, say, he was 20 years old versus the post-penile implant erection. Now, generally, we see the rigidity of the implant is more than sufficient for penetrative intercourse when used with, lubrication and things of that nature. Now, sometimes patients will still complain that it's hard to penetrate. And this is pretty rare, like because the head of the penis is floppy. Generally, because if you can implant it where the tips of the cylinders of the implant are all the way into the head, it's not a problem. But so things we do for that, in that cases, we may give patients a Viagra or Cialis that they take before sex, and with foreplay, then once the head of the penis gets engorged, they pump up the implant. So that helps to trap the blood there. And then actually really good solution for this is actually that intraurethral gel, right? So, because you're not going to put a needle in the penis anymore. That would take out the implant. It would become defective. But you can put intraurethral gel, and that actually has some good benefit with the glands engorgement. And like I said when I was talking, MenMD is one of the few in the United States that is offering that as a when I check. So I send all my patients to them for that, because it's just so you don't find it too often, but it works well in that situation. So yeah.
Alrighty, perfect. Got one VED question we're going to ask. I'm going to jump over some UI questions. So VED question is, how soon after surgery should I start pumping?
Great question. I think this is something you have to ask your prostate, the guy who takes your prostate, a guy or girl, right? So because I will have patients, and this has been cleared with at least all the urologists in my group in Cincinnati who take out prostates. We'll start patients about 4 to 6 weeks out, right? Now, the catheter generally is coming out 7 to 10 days after, and you could potentially start then, but some of the oncologists have expressed concern that, hey, look, the patient's still healing, they've been a bruising. So is that too early? And hard to know, but in the end, I don't think it's going to matter whether you wait right at day 10 when your catheter comes out and day 30, right? So we generally, just to make it, agreeable to everyone, we go a month out.
Alrighty. Moving along to those urinary incontinence questions. So this person says they would like to understand the urgency that they get since they've gone through radiation treatment for prostate cancer.
That's a great question. Yeah, so I didn't touch on that as much. So in a patient who still has their prostate in, who gets radiation therapy, the radiation that goes to the prostate sometimes scatters, and then that can also affect the bladder a little bit, right? So then the bladder has some of those radiation changes. And so when you look in that patient's bladder with a scope, a lot of times you would see what we call radiation cystitis or some irritation, like kind of looking changes. So that essentially the bladder becomes a little unstable. It starts to contract without the patient giving it volitional control to do so. And so that patient will all of a sudden feel, boom, an urgency, I gotta go. And if they don't make it, at its worst, they'll pee themselves. So that is actually urgency incontinence. So things like the sling or the sphincter I showed actually don't work for that. What we need to do in that patient is more related to first behavioral modification, so making sure they limit caffeine, making sure they're not constipated, minimizing artificial food dyes, preservatives, then medications such as what are called beta-3 agonists, Gemtesa, Myrbetriq. So these help to, or anticholinergics, which I don't love, but beta-3 agonists if you can. And so what they do, these stabilize the bladder so it doesn't do that gyration or those rhythmic contractions or spasms being the other word where you pee yourself. And lastly, if that still doesn't work, then third line is either you can put Botox in that patient's bladder, or they can get like a bladder pacemaker, such as an InterStim or Exonics, that can help to stabilize the bladder. So there's many good options there as well. But that's kind of, it's a little bit different than the patient who leaks with coughing, sneezing, laughing, lifting heavy after prostate cancer removal surgery. Yeah.
Alrighty, perfect. Next question here. So how long after prostate removal does bladder leakage last?
Well, that depends. I mean, I think patients after like the first few weeks after the catheter comes out, most patients are having a little bit of leakage, but in the majority of patients, right, that gets better where they're 0 to 1 small pad a day and they are fine. But in the patient who is really incontinent, I'm talking 12 pads a day, even with Kegels, a lot of times they may come down to 10, but that's no way of living, right? So generally we may see some recovery over the first year or so. But if a patient is still leaking, even 4 or 5 pads a day a year out, then we start having conversations about the next steps of it, like we discussed. So.
Alrighty. Next question here. Are pelvic floor exercises effective against incontinence?
Yeah, so those are the Kegels exercises that help to strengthen the pelvic floor. So doing that going into one's prostate cancer surgery and then after can absolutely help with incontinence after prostatectomy.
Alrighty, perfect. Next question here is this person wants to know if there's a way to correct their UI without using the pad. So I guess a review of the other methods.
Yeah, so correct the urinary incontinence without the pads, right? So like I said, it depends on if it's stress incontinence or urge incontinence, right? And so then like the urge stuff we just went through, the meds or the bladder Botox or the pacemaker. For patients who are leaking with coughing, sneezing, things of that nature. So you could use a clamp. That's kind of the non-surgical option if you don't want to use pads. And I mean, I guess I could show this here. I mean, essentially this pad, this goes over onto the penis like this, and then it clamps down on like that, right? So that's one. Two is the sling, right? So that's the tension if in mild incontinence and non-radiated. And now also, I mean, I didn't bring it up today, but these are kind of more, it's not experimental, I mean, it's approved in the United States, but it's not as common. So they are like these adjustable balloons that called ProAct that we're using sometimes in select patients that help to essentially buttress on the urethra and keep it continent. There's a adjustable sling that is called an Adams, which is not approved in the United States yet, but has had really good success around in Europe and Canada, which I think is going to be coming soon. So this is an evolving field, and in the sphincter as well, like we discussed, which is kind of the gold standard workhorse for really severe cases of incontinence.
Alrighty, perfect. We're going to jump around for the last few minutes of the event here and ask some questions in different categories. So we got one in the live chat right now. This person wants to know if there's any risk of their IPP reservoir rupturing if they happen to be punched in the stomach.
Depends if it's Mike Tyson, I guess, or someone who does it good. But I mean, all jokes aside, I mean, I haven't seen that, but it is possible. Like one of my colleagues in Dallas told me he had a patient who wore his belt buckled kind of there, like it was a sheriff, a police officer, and just that pressure did I don't know if it ruptured per se, but it put a leak into the reservoir. So, but that's rare, right? That's, I think it's possible, but I don't think it happens that often. I mean, I've put in, many implants, a few hundred, and we haven't seen that yet. So, yeah.
Alrighty. Next question here. It's a bit of a review of something we covered in the slideshow. You discussed a product that can combine an ED treatment as well as a urinary incontinence treatment. I believe that is at the same time they might be doing two procedures at once, but just to review that real quick.
Yeah. So okay, going to that more. So I was just that's essentially called a inflatable penile prosthesis with mini Jupette sling. So this came out of Belgium about 6 to 7 years ago, and it's a brilliant idea actually. So essentially, you put in the implant as you would, but if you look at videos of where the implant's put in, the urethra runs right through the middle, and we put it on each side. Now you can at the same time suture a sling, which is a piece of mesh, right? And that's what all slings are, right across where the penile implants put through. And so essentially when you pump up the implant, you can imagine it pulls that sling, boom, on tension across the urethra. So in patients who are leaking during intercourse, when the implant's maximally inflated, it really cuts back on that. And anecdotally, we haven't proved this in studies. We're looking at this. We are seeing that patients who leak 1 to 2 pads day to day, they can actually just leave their implant a little bit inflated, and they have noticed some benefit there. So this is, just try to show everyone that we are always trying to innovate and kind of push the field forward. And I think, so that's the procedure they were referring to.
Awesome. Alrighty. Next question here. This person wants to talk about mixing modalities. I think it would be important to talk about mixing modalities with and without an implant, because I've heard it both ways, but they just want to know about mixing ED treatments such as vasodilators or trimix and pumps, but I've also seen people ask about using those with an implant. So, away.
Yeah, I mean, I think with an implant, like I said, for instance, the glands engorgement, you can take Viagra or Cialis with it, but it's not that common, or the intraurethral gel. It certainly would never mix an implant with an injection. That's not going to work. But you can a little bit mix and match. But I tell patients that, like, let's say no implant, right? And a patient, so patients will say, okay, I want to take 100 of Viagra and 20 of Cialis, and then they kind of mix and match. You can do that, but what I say, take a step back and see what's going on. If you are having to mix and match top doses of 2 medications and you're still not getting a bang for the buck, that suggests your body needs another treatment. It's not effective. And so to keep, turning the wheels in the mud and not moving is very it's just damaging to one's psyche mentally, that you can't perform in the bedroom. It loads the relationship with one's partner, and it's stress, right? So just move on to, if you're mixing all the pills and this and that's not working, then try injections. Let's see. And if you're at high dose injections and that's not working, like I have guys who I tell them, okay, go to this dose, and they're going above that and they're still not getting erection, or like a little bit. I'm like, okay, then let's do an implant then. I mean, like, there's no reason to keep going on treatments that are futile. That's the one thing I tell patients. So we can meet a patient where they're at and get them a good solution.
Certainly. Alrighty, follow up to the combo IPP sling question, the manufacturer name, if you happen to know that off top.
No, so I mean, essentially that's there's no manufacturer. Essentially, it's whatever implant company you use. So in the United States, it's either going to be Boston Scientific or Coloplast, who make penile implants that are approved by the FDA, and then use a sling of your choosing, right? So that can be any polypropylene mesh that is off the shelf, or you can use rectus fascia as a sling. You can use fascia lata. These are essentially parts of the body that you can put. So, but it's not like a device per se that you buy as one. It's kind of putting together 2 surgeries and yeah.
Alrighty, thank you for clarifying that one. We're just going to ask a couple more questions. We appreciate you, Dr. Babbar, and everyone else being online with us. So.
Yep.
Next question here is incontinence related. This person wants to know if a sacral nerve that is damaged could be the reason why they are experiencing some incontinence.
Yeah, I mean, it could be. That's a different type of incontinence. So that's more like neurogenic bladder. So the sacral nerves are implicated in bladder emptying and filling and things like that. So generally, if someone has a sacral nerve injury, then they may actually not be contracting their bladder fully, like if they have a spinal cord transection in the sacral area, and then they may actually have something called overflow incontinence, which we didn't really touch on, but that's where a patient is not peeing at all, and then essentially it's like filling a glass all the way, and then water around it kind of overflows. So that's possible. But yeah, sacral nerve injury, I mean, could absolutely cause incontinence, but generally it's maybe a different pattern if it's a complete injury there.
Alrighty. Next question here. We got time for a couple more, but this person wants to know what they can do to increase libido without feeding metastatic cancer without testosterone. So
yeah, that's a hard one. That is, I feel for patients who are going through that, who have metastatic cancer and low T, and I mean it's hard because you cannot give them testosterone. But I think as much as one can, we know that like if you can eat healthy, sleep well, exercise, but the problem becomes you just have no motivation to exercise, and when you do, you don't see the gains that someone who has a normal testosterone would. So just all the things we've heard since we were young, about healthy lifestyle, I think, Stan, but that's all we can probably recommend in that patient.
Alrighty. Just going through our live questions here. So let's see what else we got. Is sexual sensation when having a penile implant as effective as men who try other methods for ED, I believe is what we're asking.
Yeah, penile implant should not affect the sensation to the head of the penis. There's two approaches to a penile implant. One is where you go peniscrotal, or below the penis, where the scrotum is really, and one is infrapubic, above the penis. Certainly, if someone goes peniscrotal, the nerves are on the top side of the penis, there's no risk. From infrapubic, when done in skilled hands, no problem. I guess theoretically, if someone, went infrapubic and the nerves are there and there was an injury, there would be an issue with sensation. But these are very rare situations. And, if you see a prosthetic urologist who does a lot of this, that would be very, very, very uncommon.
Alrighty, and that's going to bring us to the end of our session. If you'd like to learn more about post-prostate cancer treatments for ED, UI, and even low T, you have a few options. There will be more resources in the Resource Center on menmd.com. You can visit this page to view instructional videos, guides, expert articles, and more. That page will show you pretty much resources for any products that we offer, but we also have all the conditions that we talked about. You can navigate the MenMD website from the top drop-down, and you'll see a list of all those conditions that we mentioned today, which will then list the respective treatments underneath them. As I previously mentioned, if you have another question, or if your question was not answered tonight on the call and you'd like to follow up with someone in person, you can do so by calling MenMD at 857-233-5837. Or if you prefer, you may log into the password-protected MenMD portal to schedule an appointment with a MenMD personal health assistant. If you're interested in purchasing any of the ED or urinary incontinence products that we mentioned tonight, this is going to be over-the-counter products, as the other ones would require prescription, but you can do so by heading to the shop page on menmd.com or by calling our office again at 857-233-5837.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.